Thank you so much. I'm going to share my screen. And if you can just let me that you can see it properly.
Yes, fine.
Okay, thanks. So thanks so much for inviting me. I'll say that most of the talk today is modeling immunity is going to be focused on learning things about the biology and how to incorporate the in-host modeling aspects to the epidemiology. And there's not much math in the talk, but if people have questions about the mathematics and the models, feel free to interrupt. I don't need to get through all of the slides that I have prepared either, so no problem in asking questions. So the work that I'm going to present today is results from a very big collaboration, especially with individuals here from Jing Lauren Childs down. And then these are individuals that are help out with the epidemiology modeling. And then the in-host modeling is the people who are mainly in this first column. So I run the Modeling Infection and Immunity Lab at York University, and it's in the Center for Disease Modeling. I'm a co-director with Julien Arino, Jacques Belair, Huaiping Zhu, and James Watma. So I'm interested in all questions related to immunity. And that means that I'm interested in learning about how immunity works at the individual level, so in the host, and at the population level in different cities or geographic locations. And so we're really looking at this multi-scale problem where we try to interpret things that happen at the in-host level, at the population level, and vice versa. So one thing to remember about immunity is that it affects your susceptibility. And so you can be walking around in your geographic location, this is Toronto, and you can be exposed to different infectious diseases, and your immunity is going to protect you from two things: your probability of infection, and if you do get infected, your probability of severe disease. So if you are infected, the severity of your infection then is going to determine how much pathogen load you have in your body. And so it's going to determine how infectious you're going to be in the population. And so we're also interested in understanding how the different components of the in-host infection translate to transmissibility back into the population. So when we're looking at our modeling, we model the in-host aspects of infection and how the immune system is activated, how much pathogen you have. We look at how protected you are over time, how the immunity or protection against infection and how protection against severe disease may decay over time since last infection. When we're looking at transmissibility, we also need to incorporate how sick someone will feel, and so whether they're likely to stay home and so on. So we look at their pathogen shedding, and we use like simple area under the curve to try to quantify how sick people will be. Of course, when we're modeling the activation of the immune response, we don't just incorporate or model infection. We're also interested in understanding how the immune response is activated because of vaccination as a result of immunization. So we look at how your antibodies are developed and how they decay over time, as well as looking at your memory B cells and your memory T cells, and how long they will live in time and how specific they are to giving you immunity against different pathogens. So when we're modeling individuals in a population, we also have to take into account their behavior. So how likely are they to uptake a vaccine? How likely are they to practice social distancing? Because that's also going to affect transmissibility. And the interesting thing about this is that when you're modeling uptake of behavior and decay of behavior over time, it's very similar to how you would model at the population level increase in immunity and decay of immunity over time. So we try to combine behavior and immunity to see how these things can work together, and maybe how these will give you some oscillations in an epidemic or so on in a population. So then, of course, when we're talking about infectious diseases, I'm definitely interested in looking how infectious diseases are spreading around the world. But because my main research questions really have to do with immunity, I'm also interested in looking at how immunity moves around the world. And so what we do is we try to keep track of the immigration populations in different geographic locations globally. And then we have to keep track of what their immune systems are going to look like, depending on the vaccination programs that immigrants will have from their home country, and how that depends on age, as well as the infectious diseases that are prevalent in their home country. And so if you think about, so I live in Toronto, and I think the statistic is like 60, or maybe it's 80% of people who live in Toronto were not born in Canada. And so we have very, very large immigrant populations. And of course, that's then going to change the distribution of immunity that we have against particular diseases. And so then you can think that the immigrant population is very different in Toronto than it is in, say, Montreal or Vancouver or Winnipeg or Regina and so on. And so we have to keep track of how these immunity distributions differ in these different geographic locations, so that we can properly project what the herd immunity threshold or the distribution of immunity actually is. So we're interested in looking at the in-host infection. So we have an individual that is exposed to an infectious disease, and they have an infection. They get antibody and effector T cells that help clear the infection. And then some of these T cells change into memory cells, and they're very long-lived. And so then we're interested in challenging the in-host individual to see what their infection will be given some certain level of antibody and some certain level of memory T cells at different times in their lifetime post the previous infection or post their vaccination. So we look at these protective effects maybe a few weeks later and even a few years later. And then we quantify the area underneath these curves to give us an idea of how transmissibility is going to be different from this area under the curve to this one and to this one. And as well as we usually know that symptoms start around the peak level of infection. And so we try to quantify the level of immunity that's required to show symptoms, or the level of pathogen that's required to show symptoms, and then determine whether these individuals here will be asymptomatic infectious individuals. So for some particular infections, it's important to note that while you get some immunity from infection or from vaccination, that immunity or that effective immunity can decay over time. And this decay can either be through actual degradation or decay of the antibodies or death of memory T cells in your body. So you could be bumped up on this conveyor belt, and then your immune system can naturally decay. And we know that that is true for pertussis, for example. You get infected, your immunity decays over time. Same with for vaccination. You get your vaccine for pertussis, and then you get a booster dose, and various booster doses over the course of your life. But your immunity does definitely decay from infection and from vaccination for pertussis. We also know that this is true for COVID. But also we consider that different pathogens can evolve over time. And so your effective level of immunity is going to change. And so you can think of this for flu, where you get infected with one strain for influenza. And then over time, the pathogen is evolving, and it's evolving away from the immunity that you have. And so your effective immunity is decaying, then maybe you're going to get another strain, another infection a couple of years later, or maybe a year later, depending on how far it evolved. And that's then, of course, true with the influenza vaccine too, because it's very specific to the year that you get it. So there's a very dynamic process that has to do with effective immunity or actual immunity over time, and we're interested in understanding how this affects the in-host outcomes of infection and the population level of spread of an infection or transmissibility or persistence. Okay, so something that has been something that we've considered a lot over the pandemic is trying to quantify the level of immunity in the population in terms of seroprevalence. So here is a slide that I took from the COVID Immunity Task Force that's based mostly in Montreal in Canada, and I'm a scientific advisor to the task force. And so here what we have is an estimate of what the seroprevalence is going to be for COVID-19 over time in Ontario and in Quebec. And so these different data points are different seroprevalence studies from, say, Canada Blood Services or HEMA Quebec in Quebec, or other studies of seroprevalence that are happening in different population cohorts by province. So these different data points are used to inform a statistical model, and the statistical model is then used to determine what the actual number of infections are, and then account for seroconversion, so that you have antibodies, and then seroreversion when the antibody level will decay. And so this is an estimate of what the seroprevalence looks like in these different provinces over time using a statistical model. But we all know that we can also use mechanistic models to try to project what these distributions of immunity look like in these provinces as well. And so that's what we're going to build up to today, is we're going to look at in-host infection and immunity buildup and decay. And we're going to use all that information to inform an epidemiological model of immunity distributions by age. Okay, so our research question is that we want to quantify the level of immunity against SARS-CoV-2 over time from vaccination and infection by age, considering different variants of concern. So in order to do this, we need to understand immunity generation from vaccination, understand immunity generation from infection, and we need to understand immunity protection by age and variant of concern over time. Okay, so what we're going to do is we're going to track infections and vaccination by age in our mathematical models, so at the epidemiological level. In the in-host level, we're going to look at what the outcomes are of different immunity generations from vaccines, and we're going to specifically look at adenovirus. There's some AstraZeneca used in Canada, and mainly though mRNA vaccines. There's lots of Pfizer and Moderna in the Canadian population. And we also track the vaccination rollout over time by age and by employment as well. So we all know our healthcare workers are vaccinated as a priority. So in order to track the distribution, the change in immunity over time with infections and vaccination, we also have to incorporate public health interventions that are changing the behavior of individuals, which essentially changes their probability of being infected over time as well. And so we have to track these public health interventions, which means we take into account contact structure by age in the population and how different public health interventions change the activities of contacts of different age groups over time, because some public health interventions are going to modify the contact structure for certain age groups more seriously compared to others, like for school closure. That's not really going to affect people who don't go to school. And then we have to look at how these public health interventions affect the effective susceptibility and effective transmissibility of susceptibles and infected while these public health interventions are happening. So you can think just looking at masking, where masking will affect the effective susceptibility of people who are susceptible, and it will also affect the effective transmissibility of people who are infectious if they're wearing a mask. Okay, so when we talk about immunity, we're talking about antibodies, which help mainly protect you from infection. We look at B cell memory. We know that activated B cells can change into plasma cells, which produce antibodies, so that's important. We also look at memory T cells. So CD4 T cells can differentiate into T helper 1 and T helper 2 cells, which are then going to help activate B cells and produce antibodies, or help activate CD8 T cells, and activated CD8 T cells kill infected cells. There's also lots of other components of the immune system that we model, because we know that a lot of other components are related to these different things here, and they're easier to measure. So we're going to take different measures of antibodies as well as different cytokines in the body, which help us understand things that are harder to measure, like these different T cell here populations, which are hard to measure and expensive to measure as well. So we're going to look at how these different components help protect against infection, how they protect against severe disease at the population level and in the in-host level. Of course, we're going to look at different waning rates of immunity. We know that COVID-19 is a coronavirus, and we know that from previous studies of other coronaviruses that immunity does wane over time. So we, from very early on in the pandemic, incorporated waning immunity in all of our models. And then, of course, we're interested in how the immunity varies by variant of concern, because we're interested in immune escape mechanisms. And we know that that's especially important for Omicron. Okay, so here is an in-host model that we developed for vaccination. It's important to note that there are so many different components of the immune system that you can incorporate lots of all of these aspects. You have an insanely complex model that you won't be able to analyze, and also you won't be able to find parameters for. And we get very limited data sets that we can use to actually study the immune response. And so what we did here is we developed an in-host model where we have our antigen presenting cells. They're helping to activate the CD4 T cells, which are called T helper cells. These activated cells can either become Th1, which activate the CD8 T cells, which can go in and kill infected cells, or they become Th2, which when activated can help activate B cells, and then the B cells can become plasma cells, which make antibodies. But we don't have enough data to incorporate all these populations in the system. And so what we do is we simplify the system to just incorporate these components that are brighter. And then we have data that specifically we have antibody data and or data for interferon gamma and or some sort of interleukins that can be coupled to the Th1 response or the Th2 response. And we also have some other things like granzyme B from some of the studies. Okay, and so this is a mathematical model that we used to model the outcomes of AstraZeneca vaccination, and results are published in this paper here. So we've used a very similar model to look at the outcome of vaccination for mRNA vaccines, and it's posted on medRxiv. And we have a protein subunit vaccine study as well, where we use a similar model and structure, but a couple of other populations, because protein subunits activate the immune response in a different way. Okay, so but what's important here is that we have antibodies as an output. We also have memory CD8 T cells as an output, and sometimes our extensions also include memory B cells and memory CD4 T cells too. Okay, so looking at our study for the mRNA vaccines, which is here on the right, what we did is we fit a mathematical model very similar to this to Pfizer and Moderna clinical trial data. And so here, mRNA 1273 corresponds to clinical trial data for Moderna, and BNT 162b2 gives you outcomes of clinical trial data for Pfizer. You can see here that we're looking here at the IgG response, which is a particular antibody, and it's in arbitrary units. And so it's very difficult when we get data that's reported in arbitrary units to be able to do a comparison studies between Moderna and Pfizer. And so you can see here that it looks like Moderna is producing a much higher level of antibody compared to Pfizer, but this is in arbitrary units. So we can't do a one-to-one comparison like this. You'll see here, though, that we have some red and green that are intermixed. And so we do have one study that worked on both Pfizer and Moderna with the same hands in the same lab. And so we can have a better comparison when we look at this data. So what we do is we fit our mathematical model to all of the different studies that we have for Moderna, Pfizer, and Moderna, and so on. We use monoliths to do the fitting. So we fit all of the studies at the same time and look at how the outputs are related to each other over specific relative distributions. And then we look at what the decay parameter in our antibodies look like for our different vaccines. And so what we do is we fit the mathematical models to vaccination data. We quantify antibody output. We also quantify T-cell memory generation, which I haven't shown here. We determine estimates for decay rates of antibodies and memory cells over time. We also did the same type of thing for adenovirus vaccines. So here what we have is different points for 1 dose or 2 doses of AstraZeneca. And we fit the mathematical model to the 1 dose data and to the 2 dose data for IgG, and we also have interferon gamma data. I'll say we also have other data sets for this model over here as well, but I didn't show them. In interferon gamma, and then we look at what the outcome of the model is going to be over the longer term to look at the decay of antibodies and CD4 T cells. Okay, so something that's interesting that we also did for the AstraZeneca study is we looked at what our outcomes of antibodies and T cells would look like if we split our 2 doses further apart. So here we have the first dose of vaccine, and then we have the second dose of vaccine 21 days later or 28 days later. But so that's week 4, so 28 days later. But what happens if we spread the 2 doses apart by 6 weeks or 8 weeks and so on up to 20 weeks? And so you can see here that, of course, you're not going to get the same level of T cells or antibodies early on, but by spreading the 2 doses further apart, you maximize the level of immunity that you have over time in your antibodies and your T cells. And we did this type of study because we wanted to see, at the time, Canada was spreading their doses further apart. They had a maximized first dose coverage program because the number of doses that they had were limited and they were waiting for more shipments. We also looked at what would happen in a setting where doses were very limited, and we looked at what happens if you give a full first dose and then the second dose is a half dose or a quarter dose, and see what the outcome of immunity would be. So I'm not showing that on this slide, but if you're interested, you can go look at this paper here. So for the mRNA vaccines, what we did is look at many different outcomes with respect to immunity, but in particular, we looked at what the predicted immunity remaining in terms of % of peak would look like over time. So we take the peak level of antibodies, and then we look to see what the level of antibodies are compared to the peak level over time with the decay rates that we obtained from our model fitting. So here we have what our outcome looks like for Pfizer when the 2 doses are taken 21 days apart. And here we have what it looks like for Moderna when the 2 doses are 28 days apart. And here's the combination of the two outcomes. And so what we find is that by day 110, we have 75% loss of antibodies compared to peak level for our Pfizer fits. And for our Moderna fits, we have the 75% loss by day 141. And so we see that the decay rate for Moderna is slower compared to Pfizer, but it's important to note that by day 265, almost all of the immunity is lost for both cases, for both vaccines. And so we use this to say that, or to give, to inform public health as to when a third dose of vaccine would be needed in the population. And we did the study by age as well and by sex, and we do see a different outcome that the vaccines do decay faster in individuals that are older compared to younger. We do know that that's also true from studies in biology and immunology, and we do find that as well in our model fitting. And so we were able to say when the third dose should be implemented in different age groups using our model fitting, and it corresponded to what the CDC started to recommend for the third dose while we were doing the study as well. Okay, so we also have modeled the in-host infection of SARS-CoV-2. And again, you can see that it's a very complex thing that's happening in the body when we're infecting cells. There are lots of different stages that we can explicitly model. But again, we're going to be limited by the amount of data that we're going to be able to get from our immunology collaborators. And so on the left here is a mathematical model that we developed to look at in-host infection, where we have data from our collaborators that are related to, that are interleukin-2, interferon gamma, and granzyme B. And specifically, these are all related to activated CD4 T cells. And so we have the effects of interleukin-2, which help also stimulate the CD4 T cells. We have interferon gamma, which also helps stimulate the CD4 T cells, and granzyme B is related to the killing effect of infected cells over time. So at the top, we have what you might recognize as the basic TEIV model for in-host infection, where we have healthy target cells in the body. They're infected by infectious virus particles. Then they enter an eclipse phase where different processes are happening within the cell, transcribing the genetic information and using different proteins to infect the cell and program it to start making new virus particles. So then it becomes a productively infected cell when it starts to make new virus particles. It makes these virus particles, and there's also some cell death. So what we found in our in-host infection studies, we're looking at mild, moderate, and severe infections, where severe means hospitalized, moderate means definitely have symptoms, and mild means no symptoms. And so what we can see that when we look at, say, interferon gamma, interleukin-2, and granzyme B, for interferon gamma and interleukin-2, we definitely see that there's a differentiated outcome depending on the type of infection, where here we have green is mild, orange is moderate, and black is severe. Same for our IL-2. For granzyme B, you see that there's not as much difference in the beginning, and then over the longer term, you see a difference between the severe infections and the mild and moderate. Down here, we're showing how the model fitting looks like to specific individual patients in the study. We also have been fitting population level cohorts. So here are different studies that look at mild, moderate, and severe infections as well over different time points during the pandemic, which are important when we're looking at different variants of concern that have been happening over time. So here we have data from Goyle, which is later in infection, and that's with the historical strains, same with Neant. Jones gives us some alpha and delta. Key also gives us some delta. And so you can see what these look like, as well as we're able to use the model to look at fitting to viral load data in the nasal passage or in the saliva. Okay, but from all of these models, we gain some quantification of the buildup and decay of our memory T cells and our antibodies. And so with those models, with those outcomes, and doing a literature search and making some assumptions, we then use this information to parameterize an epidemiological model of immunity in a population by age. There are certainly some things that we have to assume. And so then, of course, we do a sensitivity analysis on those assumptions to see how our results differ. So here is our epidemiological model of COVID-19 infection in the population. And it's structured by immune system status. So here we have people who are totally susceptible to infection. And then as we move to the right, we have people who have different degrees of protection from infection and from severe disease. Okay, up to S4, here we have people who are entirely protected from infection. We also have different infections that can happen in individuals. So individuals can have a mild infection with some probability P, P1, or they can have a moderate infection with probability P2, or they can have a severe infection with probability P3. And the probability of mild, moderate, or severe infection is going to depend on the distribution of comorbidities that we have in the specific age groups that we're modeling. So this is a model for a specific age group. We model 5-year age groups. We have 16 age groups that we're modeling. And so then we have all of these different equations for each age group that we consider. So it's important to note that we also assume that if you have a severe infection, you get more immunity compared to if you have a moderate infection compared to if you have a mild infection. And that is a direct outcome from our in-house modeling studies as well. It's also been shown for some other infectious diseases that this is true. And so we inherently incorporated these steps in our model for COVID-19. We also have immunity that wanes over time. So we look at waning from S4 to S3 to S2 and S1. Our individuals in S2 and S3 can be infected, but this is a lower probability of infection. And if infected, has a higher probability of a mild infection compared to if you're in S2 and compared to S1 as well. At the same time, we incorporate our vaccine into the model where we have 1 dose of vaccine and 2 doses of vaccine. And the shading of the purple gives you the assumptions that we're assuming. So we're going to assume that if you have 1 dose of vaccine and from S1, then you have similar protective levels from infection and severe disease as an S2 individual. And if you had 1 dose of vaccine from S2, then you have a similar level of protection to an S3 individual. But for all other cases, you're going to have total protection from infection similar to an S4. And those assumptions can be modified over time when we have more information on how protection from 1 dose and 2 dose changes and how they're actually related to level of immunity that you get from infection. So in order for us to parameterize this model, we have to incorporate the distribution of comorbidities by age. And there's this this great paper by Clark that actually gives you the distribution of different comorbidities and thus probability of severe infection by age, by comorbidity status. So we use this data to inform all these Ps, which are probability of mild, moderate, and severe infection. We also have to parameterize our infection level or our reproduction number. So we have this study from Knight and Mishra that used many different statistical models to determine what the basic reproduction number of COVID-19 is in the Canadian population very early on. I think it was Ontario actually that they looked at. So we picked a value here right in the middle. And then we have some parameters that we don't know. We of course know how long the exposed period is, how long the infectious period is. So we didn't know early on how that differs between mild, moderate, and severe infection, but our in-house modeling studies give us a better idea. We assume that a moderately infected individual has a particular transmission rate, and we assume that people who are mildly infected have a lower fraction of transmissibility compared to moderate. As well, we assume that people who have a severe infection have an even lower fraction of transmissibility, because these individuals are very sick and go to hospital or indefinitely stay home. So we have a few parameters that we have assumed, like the waning rates here, same with for the waning rates for the vaccines, as well as what our susceptibilities, these alphas are, and we do a sensitivity analysis on that. Okay, but what's important to note is that we have all of this information and some assumptions for all the different age groups in the Canadian population. When we're modeling different age groups, we also have to take into consideration the contact structure over age. And so this is a synthetic contact mixing matrix from Prem, Cook, and JIT. And then what we do is we layer on top of this contact matrix what the different public health mitigation strategies look like. And so here, phase 0 is what we had early on in 2020, where we had school closure and work from home, and people weren't allowed really to go out, maybe except for once a week to buy groceries. And then we have some relaxation here where we still have school closure, but some people, there's a little bit of relaxation. Here we have schools open again, but still some work from home and so on. It's important to note that for all of these contact structures, if you look at just the total contact rate or activity levels by age, the 15 to 19-year-olds always have the highest contact rate compared to all the different age groups. And so for one of our earlier studies, when we were looking at the vaccination rollout, there was no vaccine really available to individuals that were in this age group and lower. And so one of our specific outcomes is that we found that we should be giving vaccines to this age group as soon as possible, because the direct effect in this age group is important, as well as the indirect effect on how this decreasing level of infection in this age group is going to benefit all the other age groups in the population as well. Okay. So we fit this mathematical model to infection data or to hospitalization data, but first it was mainly to reported cases. And we assume then that severe infections, which are definitely going to be reported, and some of these go to hospital. So these severe infections are definitely reported. Some fraction of moderate infections will be reported, and we do a sensitivity analysis on that assumption. And we assume that very little of our mild infections, which are all asymptomatic, will be reported. These are just people who might be going to get tested because we're going to visit grandma or so on. And so we do a sensitivity analysis on the fractions of these different types of infections that we assume. So what we do is we fit the model irrespective of age, so just look at total numbers of reported infections. And then we parse that out into the different age groups and see if our fitting result makes sense. When we incorporate vaccination into the model, we weren't sure very early on how much AstraZeneca, Pfizer, Moderna we'd be using in the population, or even some other vaccines. And so we also do a sensitivity analysis on what the protective capacity against infection is from 1 dose and 2 doses, as well as against severe disease. Okay, so when we fit the mathematical model to the data, we fit a parameter called kappa. And this parameter kappa actually incorporates 6 different components that are going to affect the transmissibility of the infection. And so it incorporates PPE compliance and relaxation, so mask wearing, social distancing, the testing rates and how they've changed over time, as well as contact tracing rates, the changes in the virus transmissibility over time, and the effect of weather on transmissibility. And so we fit this kappa to the data, And then we see what that fit looks like, and we interpret it in terms of all of these different things here. And a current project that we have is trying to parse all of these different components out of this kappa value so that we can really zoom in on the behavior aspects of the individuals in the population. So remember, I looked at the different contact mixing matrices. We labeled them 0, 1, 2, and 3. And over the different public health mitigation outputs and looking at the different contacts for each province, we're able to look at what those contacts look like and the severity of the public health intervention strategies over time. And you can see here in Ontario, this is the province that had the most strict public health mitigation, whereas these provinces here were way more relaxed in comparison. Okay, so we fit the mathematical model. Of course, because we're modeling age, we have to take into consideration the distribution of ages in the population. And we have to look at how the vaccines were rolled out in the population by age and by employment as well, and over time. So we do a sensitivity analysis too, which maybe I'll briefly talk about later, but we fit the mathematical model to reported cases. And here's what the fit looks like. So here we have daily incidence, and we're fitting our model such that we have all severe infections are reported and 80% of moderate and 0 mild. And so here the red plus signs are the data, and the red line is a rolling average of the data over time. The black here is the daily incidence of severe infections. This is the daily incidence, this dashed dot is the daily incidence of moderate and severe infections. And then of course, we also have mild, moderate, and severe infections as well, but we didn't plot that here. And so you can see that the data lies in between these two lines, and this is what we want, but we do a sensitivity analysis on these fitting assumptions as well. But when we do our fit, we then parse out where the infections are by age. And so you can see here that for 0 to 9-year-olds, we're capturing all mild, all severe, and all moderate infections. But when you go to, say, look at this age group here, we're only capturing severe infections. And it's been discussed during the pandemic that this age group here may be less likely to go get tested. Maybe that they're more hesitant, or maybe that they're working and they're trying to make money for their families. And then we do capture quite a few of our 70+ infections, and we capture all of the infections in the first wave in this age group. Here's what our vaccine rollout looks like for 1 dose and 2 doses. This is actually, we have a higher coverage, but this is just the effective doses in the population, and we compare that to the data, and it's very similar. So now what I'm going to show you is the main result of the study. And what I'm going to do is, remember, we're interested in looking at the distribution of immunity by age over time. And so here are in the next slide, the red is the different shades of red correspond to the different age groups that are in S1. The blue corresponds to the different age groups that are in V11, so 1 dose here, or are in S2. The yellow shades correspond to S3, or 1 dose from S2. And the green corresponds to all of the darker purple populations here, where they have total protection from infection. Okay, and so this is the model fit to Ontario, and we've done this for every province, but this gives you an example of what this looks like. So you can see that very early on in the pandemic, we have all susceptible individuals over time, all susceptible individuals. And then we have a very low-lying infection that is coming up in the population, mostly mild infections. And then we have some moderate and some severe infections, and those are going to provide us immunity into S2, S3, and S4 respectively. The white space up here are the levels of infection. So you can see that we had what we thought was a very big wave of infection early on, but in comparison, it's very small compared to what we had in early 2021, spring 2021. And then this is what we projected that we would have in the fall of 2021 after fitting our model. So as we started rolling out the vaccines, you can see that there's a huge increase in protection against infection and severe disease in our green, yellow, and our blue populations. And this is where our vaccination program stops in our model, and this is where we fit it. And then we projected into the fall to see what our fall would look like. So one thing that you can see here is that we see that there's a suboptimal level of immunity in these age groups here. And so one thing that we presented to the Ontario modeling table is that we need to have more 12 to 29-year-olds being vaccinated so that we can protect everyone in the fall. So we said, vaccination campaign needs to change and it needs to be targeted to the 12 to 29-year-olds. When we projected into the fall, what we saw is that we have this big increase in blue. So we have a lot of infections that are going to be mild. So these are individuals that have a mild infection, and then they enter into these immune classes here. We also have some moderate infections. We do have some severe infections. So the severe infections you can't really see them here because we have immunity waning over time, and that dynamic is overcoming the infection in the system. But you can see here, so then when we're looking at all infections, we have a lot of mild and a lot of moderate infections. So we projected that the fall wave would be less severe than what some people were discussing. But when we did look at severe infections, we were interested, so this is what our severe infections look like over time by age. And we were interested in seeing what age groups were going to be most affected during this wave in a severe capacity. And so if you look at the yellow, orange, and blue, we saw that 50% of our severe infections were in age groups 50 plus. And so this is when we recommended to the Ontario government that a booster vaccine program, so a third dose, be rolled out to age groups 50 plus, and especially to the immunocompromised in age groups 50 plus in August and September. Okay. Another thing that's really great about this model is that we can actually see where infections are coming from. And so you can see that over time, still most of our infections are coming from people who are totally susceptible. So remember, the red shades here are in the S1 class. We also see that most of our infections are coming in individuals who are 50 plus. And only a very small number of infections are coming from individuals that are in the blue, which is in the S2 type of category, and there's a little bit of yellow that you can see as well. And so the vast majority of our infections are still in our 50 plus individuals. And so carrying forward, when we're looking at the Omicron era, we're using this model to also look at when or what populations and when fourth doses of vaccines should be considered and so on. And in Ontario and in Canada, the fourth dose has just been approved for individuals 60 plus, I think. I can't remember. But the fourth dose has to be separated from the third dose by a certain period of time. And in the in-host modeling, we're starting to look at what that optimal interval should look like as well. Okay. Last thing is that it's important to see that ascertainment is going to vary or change as you gain immunity in the population. And so early in the pandemic, we had about 2.5 infections were not reported for every one reported infection. And then this with contact tracing was reduced down to 1.8 infections per one reported infection. But then as we started vaccinating, people then start getting pushed down to more mild infection if they're going to be infected. And remember that we assume that we don't capture those infections very much in contact tracing and in testing. And so after the vaccination program is implemented, we're getting about 5 infections that are not reported for every reported infection. And then even later on, the different governments have changed the way that they test. And so it's going to be even worse or different. So we did some sensitivity analysis on the waning rates, on the protective capacity of the vaccines, and so on. Here's just, what we look at. This is different fitting that we did for the different vaccines and different waning rates over time. And you can see the outcome is still very similar. And in fact, the distributions of immunity that we get from doing our sensitivity analysis don't change very much. So you can see here our distributions of immunity where we have full protection, some protection and less protection over time, that it doesn't change very much at all. And so that's an important outcome of this mathematical model, that for looking at our different distributions of immunity in our vaccination programs and our outcomes of infection, that our results that we showed for Ontario and for other provinces are pretty robust in determining where infections will be and when booster doses should be provided to different age groups. So in current work, we're updating the model to include Omicron. We're also in our in-host modeling looking at different vaccine escape mechanisms or immune escape mechanisms for the different variants of concern in COVID history. So we're trying to quantify those. We're updating the model to fit the hospitalization data. The testing data has changed in quality in all the provinces because there's a lot less testing happening. So we're modifying the model to fit to hospitalization data instead, or to death data. We're looking at what endemicity looks like in the different provinces. We're also looking at the seroprevalence distribution of immunity and how that looks like with more doses over time, maybe looking at seasonal doses of vaccine, and looking at what new vaccines will look like and project in the population as well, with different characteristics and protection. And then the last thing I already mentioned is that we're also dissecting that parameter that we fit, kappa, to really parse out what the behavior outcomes look like. So we have data on what the different virus transmissibilities look like for the different variants of concern. We have data on seasonality and how transmissibility changes for our seasons. And of course, we have data on contact tracing rates and testing rates over time too. And so if we use that data to parse out those sub-kappas, then we can really zoom in on what kappa 1 and kappa 2 are looking like. We're also applying this model to different countries. And when we incorporate many different vaccine doses, we've extended the model now to look at how our vaccinated individuals are becoming infected. And we've applied this model to France, and we're currently applying it as well to Hungary. And we're gathering data for different states and for England. And we're going to expand this model to look at many different countries and geographic regions in the future. So like I said, this is a collaborative work with lots of individuals and lots of support. Funding has come from many different funding agencies and different government contracts as well. Thanks so much. And I hope there's some time for questions.
Thank you very much for a very interesting talk that spanned a very large set of topics. So if there are questions, please, people can raise their hand or simply unmute and start talking. Well, maybe I start with a question myself. If one thing I didn't really follow in the last model, so you have these different groups of susceptible. So susceptible one are the ones that are normally before the pandemic are the one, or everybody was a susceptible one. Is that correct?
Yeah. So these are people who are totally susceptible. So that's like pre-pandemic.
And then they can become infected either mild or moderate or severe. And does that depend on age? Is there any other heterogeneity on these probabilities of going from to one kind of disease or not?
So early on, it just depends on age, but then later on, after these infections have happened and vaccination has happened, then the probabilities shift more to the mild infections. And so if you have some immunity already, then your probability of a mild or moderate severe infection is going to change. And that shift also can depend on how old you are.
Okay, but there is no effect on who infects you. It's not that if you're infected from a severely infected individual, you're more likely to become severely infected or something like that.
No, so we didn't incorporate, say, exposure to different quanta sizes, but we did assume that our moderate infections have a particular transmissibility, like our beta. And these guys here are have a smaller fraction of that beta, and then these guys have an even smaller fraction because they're severely infected and are staying home and so on. But we didn't look at quanta size, no, and we haven't looked at like households or things like that either.
Okay, there is a question by Gianpaolo. I can read it, or you can ask that yourself, Gianpaolo, as you prefer.
Okay, I will unmute. Thank you very much. It was a very interesting talk and a very complex model in many ways, but some of the basic assumptions, for instance, why would a severely infected person be more protected afterwards? Since being a severe case might be a sign that your immune system is weak, and then it will stay weak.
Yeah, that's a good question. So what we do is we quantify the outcome of the antibodies and the memory T cells. And so if you're only looking at one age group, so this is a 5-year age group, then if you have a severe infection, we're assuming that these individuals have a higher level of antibodies and memory T cells compared to people who had a moderate infection and compared to people who had a mild infection. So within your age group, that's true, but between age groups, that might not necessarily be true. We do know that decay rates change over time, and we do know that the level of antibodies and T cells that you gain after an infection can differ by age. But that's extra detail that we haven't really fine-grained into the model yet, but we can assume that, for example, that for the older age groups, we know that immunity decays at a faster rate compared to individuals that are younger. And so these waning rates can be, we can parameterize these to be faster in the older populations compared to the younger ones.
But what I meant was that, for instance, comorbidities were assumed to have a certain role for the risk of being a severe case, and the comorbidities will remain even if they survive.
Yeah, so within one age group, though, the comorbidities just parameterize these arrows. And when we do look at the outcomes of antibodies and memory T cells in the data that we get from the immunology studies, the outcomes by severity of infection are different. And we do see that, for example, when we looked at interferon gamma and interleukin 2 and granzyme B, that our severe infections had higher levels of those measures, which correspond to CD4 and CD8 T cells compared to individuals that had moderate and mild infections.
Okay, thank you.
No problem. Nice to see you again.
Other questions? Okay, sure.
Andrea?
Yes, maybe. Start.
Thank you very much for your beautiful talk, Jane. There's been a lot of talk about the problem of cytokine storm. Is that incorporated in a way in your in-host model, or well, it is more related in a way to mortality rates? I don't know, and maybe age. So what's your opinion about that story of a cytokine storm?
And so the models that I presented today don't incorporate the cytokine storm, but with a collaborator, Morgan Craig, who's at the University of Montreal, we're working a little bit on that. And she's also worked previously on trying to quantify cytokine storm in infected individuals in host. And I think Thomas Hillen at the University of Alberta has done a little bit of that as well. But I haven't really looked at that. Morgan is really interested in quantifying inflammation in people, and that's related to cytokine storms. And so if you're interested in that, I can point you towards her papers, but her name is Morgan Craig, and she's at the University of Montreal.
Thank you.
May I just interject another question? I remember one of your graphs showed seroprevalence levels,
Yes.
but they did not go very far. They went into 2021 at some midpoint or something like that. But they were quite low. I mean, they were around 8% or 6% of the population. Now, only today, 2 people I know have phoned me saying they have COVID, etc. Can seroprevalence levels really be that low in the population? I mean, the current feeling, okay, it's Omicron, is that half the people have had Omicron by now or something like that.
Yeah, so we're fitting the model for the Omicron era. So these are older results. But when we looked at the statistical model, we also see that in these different provinces, and when we're looking at seroprevalence data, so these are different antibodies that we're measuring, anti-N for infections and anti-S for vaccine, or anti-S only, I should say, for vaccination. You can see that our seroprevalence estimates from the statistical model are also very low into fall 2021. This is really a result of very strict public health mitigation in Canada, and especially in Ontario. Even in the Atlantic provinces, it's even lower because they totally closed their border for a while. There's not a lot of population in Atlantic Canada either, so we have stochastic effects, but we really do see that the seroprevalence is very low in all the Canadian provinces until Omicron comes in.
But
so this is just seroprevalence from infection.
Do you expect then that the last 6 months have seen a big increase so that now you're at 20–30% or something?
Yeah, I think even for some provinces it's up to 45%. And I like here, I had it 3 weeks ago, my husband 4 weeks ago. Almost everyone I know has had it in the past month. Very mild infection. I just had a cold.
Okay, are there other questions? I think if not, we are ready. I think there has been a very interesting talk, a lot of topics. So really thanks again to Jane. And next, so thanks a lot, really, it was really appreciated. Next seminar should be in 2 weeks, although it has to be confirmed. So we'll let you know on the mail. So thanks a lot.
Everybody.
Have a good morning, Jane, and good afternoon, all the other people here, and hope to see you soon.
Bye.
Bye. Thank you very much.